health and the prostate is a small walnut-shaped gland in males, and prostate cancer is the most common cancer and the second leading cause of cancer death among men in the United States. The good news is that prevention, screening, diagnosis, and early treatment are the key to favorable prognoses. So we have a wonderful presentation this evening. First, I'd like to thank our sponsor, which is Montefiore Nyack Hospital. And our presenter this evening is Lauren Bordeaux, who is the oncology nurse navigator at Montefiore Nyack Hospital. And with that, I'm so happy to turn it over to Lauren Bordeaux.
Thank you so much. Good evening, everybody. My name is Lauren Bordeaux, and I am a board-certified oncology nurse navigator for Hyla Medical PC, hematology oncology in affiliation with Montefiore Nyack Hospital. So just a little bit of background about me. I started my secondary education at Fairfield University in Connecticut, where I received my baccalaureate of science degree in psychology and a minor in biology in 2006, before going on to Dominican University, where I received a baccalaureate in nursing in 2011. I then graduated and became a nurse shortly thereafter and started working in pediatric home care, subsequently in inpatient psychiatry and addiction. And then I would move on to my niche, which would be oncology in 2015. And tonight it is an honor and it is my pleasure to join you in the community chat discussing men's health and specifically the walnut in the room, prostate cancer.
Lauren, I'm so sorry to interrupt your introduction. We just are seeing your desktop. So if you want to open your PowerPoint, thank you.
If I want to open, what would you want? What do you need? You're not seeing the actual presentation?
Correct. We're seeing your.
All right, let's see here. All right, so let me see if I do.
Now we are seeing your PowerPoint.
Is that better?
That's perfect. Thank you.
All right, very good. So then let's get started. All right, so we're going to be talking about the walnut in the room, prostate cancer. Today's discussion is going to address the keys to prevention or risk reduction, screening, early diagnosis, and treatment of prostate cancer in men. All right, can we see my next slide?
Yes.
All right, very good. So here we go. So what is a prostate gland? To understand prostate cancer, let's first start with the ABCs of a prostate. Specifically, what is a prostate gland and what does it do? So the prostate gland, as previously stated, is a walnut-shaped organ located in men. It matures during puberty to its healthy size, which is the size of a walnut, and it's located just below the bladder and just in front of the rectum and is pictured below for your viewing pleasure. So similar to a walnut, the prostate has two lobes, a left and a right lobe, that'll wrap around the urethra, which is, if I can point to it, the urethra, which is the organ by which urine passes from the bladder. So the prostate functions in producing a fluid that is rich in nutrition, enzymes, protein, and minerals, and it protects sperm, which when mixed with other fluids from the male reproductive system will form semen. So what happens to the prostate as men age? So as men age, it is normal for the prostate to get larger. In fact, during puberty, the prostate doubles in size. And while the actual cause of this prostatic enlargement is unknown, many of the studies have attributed this to a surge in male androgens or hormones such as testosterone. There are other factors that may be linked to aging or changes in the cells of the testicles, the primary site of testosterone production. So, for example, men who have had their testicles removed at a young age, let's say as a result of testicular cancer, do not develop an enlarged prostate. In men, typically this enlargement of the prostate is not problematic until after the age of 60. In men 25 and older, the prostate will typically continue to grow. It'll plateau in some, and it can actually reach the size of a tennis ball by the time they're the age 60. So in most men, this growth is benign, and it's called benign prostatic hypertrophy, or excessive growth of the prostate. And it's typically not problematic unless a person becomes symptomatic. So benign prostatic hypertrophy is the term that's assigned to this excessive growth of the prostate as men age. It's considered, as I said, a normal part of aging. The use of the term benign is going to imply that this growth is non-malignant. It's not cancerous. However, as previously stated, it can be problematic if symptoms, urinary symptoms, or pain appears. So some of those signs of BPH, or benign prostatic hypertrophy, are going to include frequent or urgent need to urinate, urinating more often at night, also known as nocturia, trouble starting a urinary stream, a weak urine stream, or a stream that stops and starts again, continued low volume urination when you thought that you finished, otherwise known as dribbling, not being able to fully empty your bladder, or the feeling of fullness in the bladder after completing urination. To a lesser extent, we may see sexual dysfunction and incontinence, or the inability to hold urine. So, treatment of BPH, or benign prostatic hypertrophy. Mild cases of BPH may not require treatment at all, actually. And sometimes combinations of treatments may work best. In addition to medical options, there are lifestyle changes that we can make that can help reduce symptoms. And some of these lifestyle changes would include drinking less, especially within an hour or two of bedtime, limiting caffeine and alcohol, which can be irritating to the bladder and make your symptoms worse, eating a healthy diet, low fat, low carb, high protein. Proteins help cells in the body to heal, to replenish, and restore themselves in times of illness. Becoming more active and exercising regularly. So the American Heart Association recommends that all capable persons exercise 5 days, a minimum of 5 days a week, for at least 30 minutes, participating in moderate to intense exercise, which will increase the heart rate about 20 to 30 beats above your personal average, for a total of 150 minutes a week. So that sounds like a lot. I say do the best you can and try to reach that goal, essentially. Maintaining a healthy body weight, a body mass index less than 30, but ideally less than 25, can help reduce the symptoms and the pressure on the bladder from BPH. So I mentioned earlier that there were medical treatment options, and these options are explored in more severe cases where BPH symptoms are impacting a man's quality of life. In these circumstances, medications may be prescribed to reduce urinary retention or involuntary holding of urine in the bladder. It'll also help to improve the flow by decreasing the prostate tissue inflammation or the swelling from the tissue overgrowth. Other medical treatments and options to reduce the symptoms of BPH in much more severe cases can include surgery to decrease the size of the prostate. So prostate cancer risk reduction. And I really just want to point out that I really toyed with this slide because it was previously labeled prostate cancer prevention. And then I realized you can't really prevent 100% of disease in anybody. So I think that the idea is not necessarily to prevent something from happening because we can't, but more so to reduce our risks of developing a disease. So prostate cancer risk reduction. Before we get started on this slide, I think it's important to note that there were multiple community-based studies throughout the United States that all came to the conclusion that 30% of men with BPH will develop prostate cancer within 5 years of their diagnosis. So how can we prevent or reduce your risk of becoming one of these statistics? And like I said, I use that term quite lightly because in life there's no 100% guarantee, and prevention of disease 100% is not guaranteed, but there are steps that we can take to reduce our risk. So number one, early screening. The USPSTF, I know that's a mouthful, the United States Preventative Services Task Force recommends screening men every single year annually at an examination starting the age of 45. So how do we do that? That's how do we screen? That's a nice segue into number two, a prostate-specific antigen or PSA examination. A PSA is a test that measures the amount of protein produced by cells in the prostate gland, both cancer cells and non-cancer cells. And this is released and circulated into the blood. So a PSA test can help in early detection of prostate cancer, essentially, and prostate problems, excuse me. So typically, the doctor is looking for PSA levels, or this protein circulating in your blood, released from the prostate gland to be less than 4. That number should be lower in patients that are of low risk. It should be noted, like I said, that other conditions besides prostate cancer can increase your PSA levels. Some of those are that BPH that we discussed on the previous slide, or that enlargement of the prostate tissue, as well as inflammation of the prostate, also known as prostatitis. So other notes about the PSA are that PSA levels naturally increase as men get older, which if we think about what we discussed a few slides ago, and again on this slide, about the natural process of aging and the prostate getting larger. So if the prostate is getting larger, that means that there are more cells. And if there are more cells, then there's more PSA protein being released into the blood. So seeing a slight elevation in a PSA level is not uncommon as men get older. Now, what allows your doctor to differentiate between benign or non-cancerous PSA levels and malignant cancerous PSA elevations would be number 3, a digital rectal examination. So a digital rectal examination allows clinicians or your doctors to examine the physical changes that take place in the prostate over time. In patients with BPH, this previously firm and smooth walnut-shaped prostate will become boggy, soft, and sponge-like. In men who develop prostate cancer, the prostate becomes hard and nodular and misshapen on physical appearance. So now that we are all experts in prostate physiology and functionality, PSA levels, and BPH, we're going to take a test. Just kidding. We're not going to take the test. But now that brings us to the meat and potatoes of tonight's presentation. What is prostate cancer? So prostate cancer begins when previously normal cells in the prostate gland develop changes in their DNA or their genetic makeup that causes them to grow and divide more rapidly without a set lifespan. So what do I mean when I say a set lifespan? Well, normal growing cells in all organs and parts of the body will undergo a lifespan cycle. They're born, they will mature, they perform their necessary functions in the body, and they eventually die. After they die, they are recycled, they're processed out of our system, and new cells will take their place. When cancer develops, these abnormal cells continue living, and they're often hidden from the body's defense mechanisms, our immune system, who plays a role in getting rid of old abnormal cells or cells that are not functioning properly. So because these cells in the prostate are allowed to grow and divide without a lifespan, unregulated, they accumulate and they form a tumor. As the tumor grows, some abnormal cells can break away and spread to other parts of the body, and this is called metastasize. But we'll talk about that in a few minutes. And if you look at the image over here to the right of the slide, just right in this area, you can visualize a picture of a tumor growing within the prostate gland. So this abnormal tissue growth can affect either lobe of the prostate or both lobes in some cases, and it causes the prostate to become enlarged, change shape and contour, and in some cases it becomes inflamed. And as you can see in this picture, I hope you can see in this picture, it's the tumor is inside of the prostate is pressing against the urethra, which I previously discussed as the passageway of the urine out of the body. So these things can all cause PSA levels to increase. In more subtle cases of prostate cancer, so people who are less symptomatic or have early disease or well-controlled disease, PSA levels may be low. So PSA levels by themselves cannot be diagnostic of prostate cancer. So just to remind you, PSA is that protein that's produced by the prostate tissue, both in healthy and unhealthy cells in different quantities, depending on different conditions. All right, so prostate cancer facts. So the term incidence is used to discuss the number of new cases of a disease for a given period of time. So with that being said, the American Cancer Society has estimated that in 2024, there will be about 299,010 new cases of prostate cancer. The term mortality discusses the number of deaths from a specific disease. So that number for prostate cancer in 2024 is estimated to be 32,250. Prostate cancer is more likely to occur in older men. And in the United States, about 38.2% of new cases in 2023 were diagnosed in men between the ages of 65 and 74 years old, with the median age of 66. And the rate of prostate cancer increases from 1 out of every 350 men, which if we do the math is 0.003% of men under the age of 50 to nearly 60% of men over the age of 65. It's pretty rare that prostate cancer will occur in men under the age of 40, but there are exceptions, and we will discuss this shortly. And some more statistics: 1 in about 8 men will be diagnosed with prostate cancer in their lifetime. Now, each man's risk of prostate cancer can vary based on his age, race, ethnicity, and other factors. So that brings us to the risk factors for prostate cancer. So a risk factor is going to be anything that increases the chances of a person, in this case men, developing a particular disease, in this case, prostate cancer. So some risk factors can be changed. This is known as a modifiable risk factor. An example of a changeable or a modifiable risk factor would be smoking. A person can change their environment or a behavior taking place in their environment, for example, stop smoking to reduce their risk of development of a disease. Let's just say smoking and lung cancer. So they stop smoking, it'll reduce their risk of developing lung cancer. On the other hand, exist risk factors that cannot be changed. These are known as non-modifiable risk factors. For example, race, age, genetics. So if you remember a few slides back, we discussed that DNA changes or genetic makeup changes in cells, prostate cells, can cause the formation of cancer cells in the prostate. So these factors, these non-modifiable risk factors, cannot be changed by change of behavior or manipulation of one's environment. That being said, the risk factors for prostate cancer include older age, 65 to 74, race and ethnicity, with African American and Caribbean men of African descent being at increased risk of development of prostate cancer in their lifetime, and family history, having a first or second degree relative with prostate cancer will increase the chances that a man develops prostate cancer during his lifetime. So on a previous slide, I discussed 45 being the age for screening to start. But if a man is 40 years old and has a first degree relative, a father, or a second degree relative, a grandfather with prostate cancer, screening will start earlier. Now, this familial link to prostate cancer makes sense if you think about it. This is because family members share a lot of genetic makeup. I mean, after all, they are related. So in some cases, genes can be passed on and subsequently inherited by later generations, leaving people more susceptible to inherit flaws in their genetic makeup called gene mutations. In prostate cancer, some of these genetic mutations can be a BRCA1 gene or a BRCA2 gene, or even a Lynch syndrome gene. Now, when we talk about disease and morbidity, or multiple diseases and multiple morbidities, there exists substantial proof that risk factors, such as the ones I'm about to review, on the right-hand side, influence the presence or absence of disease development. For example, obesity or being obese will greatly increase a person's risk of developing heart disease or cardiovascular disease. Or high blood pressure, let's say. So these risk factors listed on the right have not yet, and that is a big yet, proven by overwhelming scientific research to impact the development of prostate cancer. But they've shown a lot of promise that if we can mitigate these risk factors on the right, and I think it should be on your right as well, it's on mine, that if we can mitigate these risk factors, that we have the potential to inhibit the development of cancer in general, prostate cancer included, but also control other diseases as well. So these risk factors are diet, obesity, prostatitis, which is that inflammation of the prostate gland, leading to chronic obstruction of the urine, getting stuck in the bladder because it cannot pass through the urethra, untreated and repeated sexually transmitted infections, and vasectomy as well. Okay, so we've talked about the physiology, the functionality, the overgrowth or BPH, statistics, PSA, risk factors for prostate cancer. But how do you know if you don't know? So what are the symptoms of prostate cancer? Prostate cancer often has no symptoms in its early stages, but some men may experience symptoms before their diagnosis. These symptoms can overlap with symptoms of BPH, but there are subtle differences and tend to be more severe than BPH symptoms. And they usually are so severe that they would prompt a man to seek medical attention from his provider, which would ultimately lead to a diagnosis. So these symptoms can include urinary symptoms, frequent urination, especially at night, that nocturia, difficulty starting or stopping urination, a weak urinary stream, blood in the urine, which can make the urine appear pink, red, or brown. There may be ejaculation symptoms such as painful or burning during ejaculation, pain or burning during ejaculation, blood in the semen, decreased ejaculation volume. Some men may experience sexual dysfunction, and this is more noticeable in men under the age of 65. And then we have some lower extremity symptoms, frequent pain or stiffness of the lower back, the hips, or the upper thighs, swelling in the lower extremities, and that's usually due to the pressure of the tumor on the blood vessels of the lower parts of the body, or even the lymph nodes and the lymph draining down there. So you end up retaining fluid in your legs, your thighs, and your feet and the lower extremities. And then we have advanced prostate cancer symptoms, which are much more defined. So we can have patients present with bone pain and the swelling in the lower extremities. They may have pelvic pain, weakness or numbness in their legs or their feet, loss of bladder control, or that, incontinence, unexplained or unintentional weight loss, unexplained fevers, fatigue, difficulty breathing. So these are all some of the symptoms that can take place with prostate cancer. So prostate cancer diagnosis and staging. Diagnosis takes place through multiple methods. And while we've talked about a few of these things before, I want to go into more detail with each of them and dive a little deeper into how they work together with one another to give a complete and accurate diagnosis. So the first thing we discussed before was the DRE, the digital rectal examination. And this is going to be when the doctor inserts a lubricated gloved finger into the rectum to feel the prostate gland. Now, if you recall from about 8 slides ago, maybe, a normal prostate is going to feel firm, smooth, and is walnut-shaped. And in patients with prostate cancer, this previously smooth walnut-shaped organ becomes hard, nodular, rough, and misshapen. This change is due to the overgrowth of the tumor cells. And this may or may not be similar to the previously existing prostate tissue. So in correlation with your digital rectal examination, your doctor will also draw that PSA, or that prostate specific antigen blood test. Now, again, that PSA is the protein that's released by the prostate cells that circulates in the blood. And typically, since these prostate cells are growing uncontrollably and very rapidly, what they tend to do is raise that PSA level pretty quickly. So remember, our goal is to keep that number under 4. That's where we like to see it. So once these 2 exams have been completed, a patient may be referred for tissue confirmation of prostate cancer. And that's going to be through a prostate biopsy, during which a sample of the prostate gland is taken to check for cancer. So just as important as the above mentioned tests, imaging studies are completed to assist your provider in identifying the extent of prostate cancer disease. So some of these examples of imaging studies that can be conducted are an MRI of the prostate that can show if cancer has spread outside of the prostate into nearby structures, such as seminal vesicles, or into the lymph nodes. Another more in-depth study, and you're going to have to bear with me with this one, is called a PSMA PET scan. So I know it's a mouthful, but that's also known as a prostate-specific membrane antigen positron emission tomography. For the sake of language and the sanity of all of our listeners, we're just going to call it a PSMA PET scan. So this test injects via an IV a radioactive dye that will bind to prostate cells to help identify and locate prostate cells throughout the body. And it does so by attaching to PSMA proteins that are produced by prostate tissue. So I explained before that PSA is produced by prostate tissue. Well, PSMA is produced by the cell membrane, or the outside portion of the cell. And cancer cells, because again, they're growing rapidly and out of control, they produce this PSMA on their outside coating much more rapidly. So this dye will attach itself. It has an affinity to this PSMA that's on the cells. And wherever they're located in the body, it binds to them. And then the PET portion of the examination, or the positron emission tomography portion, will then highlight these areas. And it'll produce a picture for the doctors to see how far disease is. So where disease is located, it'll light up, kind of like lights on a Christmas tree. You put them in certain spots and then you flip a switch. So when we flip that switch on, we'll see the areas where the radioactive dye has bound to this PSMA to see if prostate cancer has left the prostate to other parts of the body. So a third exam that can be done in diagnosis is called a nuclear bone scan. This type of scan is similar to the prior exam, except it's focusing on the bones. It can tell doctors if cancer tissue is existing in the bone. So it uses the same idea of a radio tracer that binds specifically to the bone lesions. And then again, pictures are taken. And if there are lesions of prostate cancer or any cancer on the bones, it'll light up, very similar to a Christmas tree lights. You flip the switch and the lights go on if there's prostate cancer existing on the bone. And if you look just to the right of the slide, if you look all the way down where it says stage 4, it shows a little lesion on the bone. So that area on a nuclear bone scan will light up. Okay, so aside from the DRE, the PSA, the imaging studies, there are more expensive and less widely used tests. And these tests are usually used in the very elderly and frail due to high risk of bleeding or complications from a biopsy. So these two tests are called, one of them is called a PHI index, or prostate health index. It's a blood test that uses 3 different forms of the PSA to calculate a score to determine the probability that if a biopsy was done, it's going to be a high-risk cancer. The other test would be prostate cancer gene 3, or a PCA3 urine test, which looks for the excretion of genetic material from cancer cells, from prostate cancer cells. As they replicate, they excrete portions that they don't need. And part of that genetic portion that gets excreted is called the PCA3. It'll excrete it into the urine, so they can collect urine to test for prostate cancer as well. Although this test is not as efficient as the prior ones that I discussed. So I know this is getting a bit wordy. I know there's a lot of medical terminology, and I would be happy to explain it all to you once we're done, but let's move on to staging. So staging is the term that is given to identify the extent of disease within the body. When we discussed those imaging studies, that gave us some information about staging, finding out how far prostate cancer disease has spread. So there's different stages of prostate cancer. So if you look at the image over to the right, stage 1 and stage 2 prostate cancer typically are encapsulated. They remain within the confines of the prostate gland. They have not yet extended into the surrounding tissues. So if we look at this image here, we can see where the tumor has formed. We can see our prostate gland, and then we see this thin layer outside, which is the prostatic capsule. So the tumor in stage 1 and 2, the prostate is still intact. The cancer is still located inside of the prostate. Once we get to stage 3, we see penetration of that capsule by the cancer into nearby tissues or into nearby lymph nodes or regional lymph nodes. And then stage 4, as you can see, the cancer is spread to other areas, such as the bone in this example, but it can also spread to the liver, to the lungs, and to the bladder. So now on this slide, we talk about something that we didn't previously discuss. During a prostate biopsy, samples of the prostate are taken, and then these samples are looked at under a microscope. And they're given a specific score, and this is called a Gleason score. So Gleason scores can actually impact staging as well as treatment options for prostate cancer. So here you have listed the risk group, very low to low, intermediate, and high to very high, as well as the Gleason scores that are associated with these types of cancers. So I just want you to take into account that treatment decisions are not just based on staging or PSA levels, but also these Gleason scores as well. We look at patient performance status and clinical guideline recommendations when we decide on treatment options. So the Gleason score is a grading system that is used to determine the risk of prostate cancer spreading and helps healthcare workers develop treatment plans. So the score is basically the sum of two scores or grades that are given to the majority of cells in a sample that is taken. I know it's confusing, so I'm going to give you an example. If we took two biopsy samples, and between the two biopsy samples of the tissue, there are 10 cells, and 4 of those cells are given a grade of 3. One is given a grade of 4, and 5 of them are given a grade of 2. The Gleason score would be equal to 3 plus 2. It's the majority of cells grades. So of the 10 cells, 2 of the most common grades are added to give a total score. All right, that was the math lesson for the evening. So let's move on to take a look at how Gleason scores help the doctor determine the extent of which prostate cancer cells have mutated from their original form and how effectively they're replicating in their new forms. So we talked about Gleason scores being the sum of two scores. This is a range from 2 to 10, and the chart will help us to identify whether it's low, medium, or intermediate, or very high risk. So when we look on the left, we see very low or low grade risk prostate cancers typically have what are known as well-differentiated cells. These cells look and behave very similar to a normal prostate cell. And they replicate and they multiply at a rate similar to the normal cell, pretty slowly. They undergo a cell life cycle that's not too different from the normal cell. These prostate cancers have a low risk of spread and yields Gleason scores of 6 and less. Now, intermediate gets a little more complicated. So intermediate grade risk prostate cancers typically yield what's called moderately differentiated cancer cells. And they look and behave slightly different than a normal prostate cancer cell, but share some similar features. And they replicate a little faster than a normal prostate cell. In this intermediate grade risk, we can further divide into 2 subgroups, unfavorable and favorable in prognosis, or the predicted outcome of the disease. Favorable, yielding a better outlook for patients, and unfavorable, meaning the opposite. So when we look at this chart, here we see with intermediate that Gleason score 7 can be graded as 3 plus 4 or 4 plus 3. One is favorable, one is unfavorable. So we see that not all Gleason 7s are created equally. This phenomenon has been extensively studied in research, and there was a 2009 study by a researcher by the name of J.R. Stark. And what Stark found was that out of 693 prostate sample specimens, patients with a standardized Gleason of 4 plus 3, or that unfavorable intermediate risk group, were 3.1 times more likely to have a lethal or deadly prostate cancer than those who had the 3 plus 4. So there's different ways that we look at that. Moving further down the chart, we can look at high to very high risk grade group with Gleason scores of 8 to 10. These prostate cancer cells are what we call poorly differentiated, meaning that they look and behave nothing like the original normal prostate cancer cells. They're very different than what the cell looks like, and they replicate very efficiently, and they grow very fast. Depending on the grade group, so if we go down to the bottom half of this slide, depending on the grade group, we have low, intermediate, or high risk and treatment options available. I'm going to highlight them, and I won't go into too much detail because I don't want to run out of time. I want to give you guys time to ask questions if you have any. For low-risk prostate cancers, we do surveillance by monitoring the prostate cancer through PSA levels, through symptoms. We can do surgery to remove the prostate, which is called the prostatectomy, where a part or all of the prostate can be removed. We could do radiation therapy, where we put seeds inside of the prostate, or we can use energy beams to destroy cells. Men with intermediate, we can do, and other tests can be done, like that PCA3 urine test can monitor the levels as well in those low risk. So that falls under surveillance. So when we head over to the intermediate grades, depending on whether it's favorable or unfavorable, surgery and radiotherapy with or without chemotherapy, with or without hormone therapy. And hormone therapy, what it will do is it's going to suppress the testosterone. It's also known as androgen deprivation therapy. We decrease the testosterone. Now, if you remember what I said about testosterone, testosterone levels increase, and they can cause the prostate cells to grow faster. So if we suppress the hormones and suppress the testosterone, the idea is that we suppress the prostate's ability to produce new cells. Also, there's options for immunotherapy. And in high-risk cancers, we use a combination of all of these things to control disease. Now, this is the final slide, I promise, and then we'll get to the Q&A. So I would be remiss if I didn't take time to discuss advanced prostate cancer. And that's usually because prostate cancers can be caught either very early or very late, depending on how serious people take their symptoms. So when we talk about advanced prostate cancer, we look at things like, has the prostate cancer spread to other parts of the body? If it has, that term is called metastasize. So if you look at this concept map and we go to the yes, we say, did the cancer respond to medical or surgical treatment to lower testosterone? So that's going to be that hormone suppression. If it did respond, then the cancer is called metastatic because it spread. Castration-sensitive prostate cancer. And that's because we chemically or surgically castrated the males by decreasing their testosterone. Now, if the cancer does not respond to medical or surgical treatment to lower testosterone, but it has spread to other parts of the body, this is called metastatic castration-resistant prostate cancer. So now we go to the other side, and has the prostate cancer spread to other parts of the body? No. But did the cancer respond to medical or surgical treatment to lower testosterone? If yes, then it's called non-metastatic because it hasn't spread, castration sensitive, responding to the hormone deprivation therapy, prostate cancer. And if it has not spread and is not responding to surgical castration or medical castration, then we call it non-metastatic castration-resistant prostate cancer. Now, I know that was a whole lot of medical terminology and a lot of information in a short amount of time. So I am going to turn over the table to you guys, the listeners, to answer any questions that you guys may have regarding prostate cancer and, diagnosis, treatment, and prevention.
Lauren, thank you so much for this presentation. I think I speak on behalf of everyone that it was super informative. And so I know I was taking my own notes for the men in my life. So perhaps others were doing the same. As Lauren said, we're opening it up for Q&A. So you can feel free to drop any of your questions in the chat at this time, and we will field them there. I know it was a lot to take in. Um, Now, Lauren, I know that you are reachable at Montefiore Nyack Hospital if anybody, let's say, maybe thinks about it this evening or, during the weekend when they have more time. Um, is there a way that they can reach you or, someone you suggest we can reach out to if we have, further question or concern, or maybe, we speak with our loved one and they say, oh, I never knew that. Who can I reach out to?
Absolutely. So I'm going to go ahead and drop my email into the chat so that everybody has that. And I will also put in my phone number for the work line. So if anybody has any questions, they can also reach out to me there. I can provide resources for patients or for people or the men in your lives that have any questions regarding prostate cancer diagnosis, treatment, BPH, urinary symptoms, if we're not sure what we can do. So my information is there as well.
Thank you so much. That's super generous. If anyone can't take it down right now, we can send it to you after, along with any other resources that Lauren's able to share. But I would encourage everyone to, again, whether this is for you or for the loved ones in your life, to just encourage yourself or others to take advantage of screening, because that's what it sounds like, Lauren, right? Is the
Absolutely.
saving grace in all of this.
Screening, 100%. So screening for all cancers, not just prostate cancers, is the key to early intervention, and early intervention saves lives.
Which, in the world of today, I guess, is really, again, a saving grace, because there is something we can do. Many things in health, right, and biology are out of our control, but just getting checked and asking the questions, and we know our bodies and ourselves, right? We kind of know our norm. So if something seems small, but it's out of the norm, it's worth that phone call or that hour that you go to your MD. Just take that hour on your lunch break and go over. And we are so fortunate in this county that we have Montefiore Nyack Hospital. It's right here. So no matter where you are in the county, it is reachable. And they are out and about in the community as well at different events. So there's always a way to reach out to them.
Absolutely. I do see that there is a question in the Q&A from Jillian Best that says, how can I make an appointment for my husband? So we start with our primary care doctors. We go to our primary care doctors and we tell them, I'd like to be screened for prostate cancer. And from there, they'll do the appropriate testing with a PSA draw, a DRE, depending on the symptoms. Some men are more inclined to say, let's start with the blood draw before we go to the digital rectal examination. But if they're very symptomatic, then we're going to want to do more.
Great. Thank you for the question. And thank you, Lauren, for fielding that.
Absolutely. Absolutely. And again, like I said, I am always available. I am here at Montefiore Nyack Hospital Monday, Tuesday, Thursday, and Friday from 7 a.m. till 5:30. That phone number is a direct number. That email is my direct email. You can email questions or concerns. You can reach out to me. I do education all day long, so it's definitely something I enjoy doing. So.
Thank you, Lauren, for that. Is there an age you would say that's appropriate for, let's say, younger men to either start being aware or doing a screening every other year or every X amount of years?
Absolutely. So again, the United States Preventative Services Task Force sets forth the guidelines for primary care screening. And typically that's going to be for men aged 45 and older. However, like I said, if a man is having symptoms at 35, any of these symptoms, then we should get screening done. And it's just really having a conversation with your doctor that's so important. You need to speak with them. They need to know what you're feeling and what you're going through. There's no suffering in silence when it comes to healthcare. Men whose father or grandfather had prostate cancer at age 40, they should have that conversation with their doctor. Hey, my grandpa passed away from prostate cancer, or hey, my dad had prostate cancer. What is my risk? And then they can be screened appropriately at younger ages.
Thank you for that. Yes, because I believe at younger ages, we don't really think about these things. We tend to feel that we are immortal and that that's a faraway thought and it only happens to an upper age, let's say. But unfortunately, it seems that it can happen anytime. So it's important to
You know, just to build on that point, yeah, we feel invincible. We absolutely do. From 2007 till 2014, what we saw was a huge decrease in the amount of prostate cancer screenings. But we saw an increase in the amount of prostate cancers developing. So they were trying to toy with the idea of why is this happening? And the only thing that they were able to come up with, and the only thing the only answer researchers came up with, was that the guidelines for prostate cancer screening changed. It used to be screening at age 40 for all men every single year at their annual physical, and then it changed to 45. And like I said, what they did see was this increase in prostate cancers, but a decrease in screening. And that's because the guidelines changed. And that's not just prostate cancer. That's actually true for multiple cancers. In fact, a new study just came out about cervical cancer in women, but that's for another discussion and another talk.
And we will definitely plan to have you back, Lauren. I do not see any other questions in the Q&A, but again, I know this was a lot of information, which is a positive in this case. And if you think of anything at all, you can reach out to us or Lauren. And if you reach out to us, we will put you in contact with her again if you're not able to take down the contact information at the time. We would like to thank you all for joining us this evening, for taking the time to make your health a priority or the health of your loved ones, hopefully both. And we encourage you to continue to do that because our health is really the greatest blessing. We are getting a lot of thank yous, Lauren, in the chat. We appreciate your presentation. I know it was done with so much thought and detail, and everything you do within your role at Montefiore Nyack Hospital. On behalf of Finkelstein Memorial Library, who's one of the sponsors this evening, we thank you also. We have tons of resources at the library, whether it's using the computer to look things up or books or contacts and resources that we have visiting, including Montefiore Nyack Hospital every first Friday of the month. And we, of course, want to thank Montefiore Nyack Hospital for hosting. They are an incredible community partner of ours. And last, but certainly not least, Lauren Bordeaux for, again, just a really wonderful presentation.
Thank you. And thank you all for your time and attendance.
Have a great evening, everyone.
Have a good night.